Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs in the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Great. Before we get to today's questions, I want to invite our listeners to send us their questions for Dr. Mingle. You can leave your questions in a comment on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. Our first question today is from Crystal, and Crystal asks, can you explain the web interface for quality reporting? We are a part of an ACO that has many different EMRs, and we are unable to submit an ECQM QRDA.
Crystal, great question. Perhaps a little more complex in the answer than you may have been hoping for. Let me first explain the CMS Web Interface and then your options to move away from that. First, the CMS Web Interface has been an option for quality reporting since about 2013. It's been a requirement for the Medicare Shared Savings Program ACOs to meet their quality reporting obligations, and it's been an option for group practices with 25 or more providers to meet their MIPS quality reporting obligations. In the current model of the web interface, Medicare delivers to each participating practice or entity at the close of each performance year a list of attributed patients eligible for each of the 10 measures of the web interface. The entity is required to report performance against the measure on the first 248 patients on each measure's patient list. 248 patients for each measure multiplied by 10 measures equals 2,480 chart abstractions to complete each episode of quality performance analysis. It seems a daunting task until you realize first, many of the measures group together so that a single chart abstraction serves multiple measures. And second, when your provider group is more than 25 providers, as it pretty much has to be to use the web interface, it averages out to less than 10 patient charts per provider per measure, which is really quite doable in healthcare systems that may be caring for hundreds of thousands of patients. The annual process compares favorably in effort and costs to the electronic processes required to tame the data chaos that exists in most healthcare communities. If your goal is a simple annual estimation of quality performance on a statistically significant sampling of patients, you would continue to use a web interface, chart abstraction process, or something like it. But annual chart abstraction is a dead end that doesn't lead to many other great things that should come from your quality measurement system. The data and processes behind annual quality measurement and reporting have many other potential uses that are desirable in a system of high value care. Performed repeatedly, it's the foundation for a quality improvement system. Annual measurement is just too infrequent to drive quality improvement. You need at least quarterly, if not monthly or weekly measurements to power any credible quality improvement process. It's also the same data you need for analyses of gaps in care. Your quality assessment system should ultimately be usable at the time and place of care as a decision support tool. The same data, the same process, refreshed at least weekly, if not daily, or at the moment of care. The value of care is not restricted to our Medicare patients, to which the web interface is limited, but it's applicable to all patients of all payers. And finally, ultimately, when we have mastered the infrastructure, overall quality of our care is not dependent merely on the care of diabetes, hypertension, and depression, as implied by the APP measure requirements, but by our success distributing tens of thousands of evidence-based rules that are found by close scrutiny of healthcare literature. For these and other reasons, Medicare has decided to sunset the web interface quality assessment system in favor of measuring quality of care across all patients and all payers. The current expectation is that you can still use the web interface to assess the quality of your care in your ACO for the 2023 and 2024 performance years. After that, you'll need to use ECQMs or MIPS CQMs to measure the quality of care in your ACO for all patients of all payers. Getting back to your core question, where you imply that you have two choices: ECQMs that won't work for the reasons we're all intimately familiar with, and the web interface that's expected to sunset after the 2024 performance year. Let's face it, ECQMs are just not ready for prime time. In the long run, I think there's far too much to the technical side as web interfaces to the manual side. I don't think they're ever going to be suitable for a robust system of measurement. I think the only affordable, scalable, and sustainable systems will be built on MIPS CQMs. Here at Mingle, we have been making MIPS CQMs work in complex environments and successfully and affordably normalizing data and matching patients across disparate electronic health records and practice management systems for over a decade. You should engage us and put us to the test for your 2023 performance year. You owe it to yourself to your patients to prove that we can solve this problem for you before you waste 2 more years on the web interface or blow your budget on an unsustainable ECQM infrastructure.
Great question, Crystal. Thank you. Our second and final question today is from Di. And Di asks, if you are participating in a Medicare Shared Savings Program, ACO, what is your MIPS requirement? Is promoting interoperability still required?
Oh, great question, Di. It depends on two things. First, is your MSSP an advanced APM or a MIPS APM? If your MSSP is an advanced APM, what is your participation status? Are you a qualified participant, a partially qualified participant, or neither? So first, let's dig into the advanced APM versus MIPS APM. Your entity leadership can tell you which your MSSP is. It depends on the level of risk your ACO is accepted through contract with Medicare. Risk is all about actual cost versus predicted cost of providing 1 year of care of health care to all the patients attributed to your ACO. All MSSPs, whether it's an advanced APM or a MIPS APM, share in savings if your total cost of care for your patient panel comes in under budget. Advanced APMs typically have the potential to earn a larger share of any savings than does a MIPS APM. But to earn that right to a larger share of the savings, Medicare requires your ACO take more than a nominal amount of downside risk. Downside risk means if your ACO comes in over budget on the cost of 1 year of care for your attributed patients, the ACO will share in the loss. Medicare considers 8% to be the threshold for that defines nominal risk. If, when there is loss, your ACO does not share in the loss, then yours is a MIPS APM. If you share in the loss, but your share is under 8%, yours is a MIPS APM. It's an advanced APM if the ACO will collect a share of any savings generated, and if there's a loss, the ACO will be liable for 8% or more of that loss. So what's it mean? If your MSSP is a MIPS APM, you are subject to MIPS scoring and adjustment. It's not exactly the same as the general MIPS requirements, and I'll get to the differences in a minute. If your MSSP is an advanced APM, your MIPS requirement depends also on your status in that ACO. Status relates to what proportion of your eligible patients are getting their care through the ACO. Essentially, patients can choose whether to participate in the ACO process or not, knowing that there are benefits and potentially risks or limitations to their care. Participation is measured both by the proportional amount of charges and by the count of patients. You're judged by whichever calculation is most favorable to you. There are two thresholds for that number. If you meet the higher threshold, you are considered a qualified participant or a QP. If you meet the lower threshold but not the higher one, you're considered a partial QP. If you did not meet either thresholds, then you are subject to MIPS. If you meet the lower threshold as a partial QP, you can choose whether or not you'll participate in MIPS. Theoretically, if you know you're going to get a positive adjustment, you'll participate. And if you know you'll get a negative adjustment, you would not. If you're in an APM and subject to MIPS, scoring is a little different than for mainstream MIPS. Cost doesn't count into your MIPS score because cost performance is accounted for contractually with Medicare through shared savings or losses. Quality accounts for 50% of your MIPS score, unlike the 30% that the rest of the MIPS environment is subject. Improvement activities account for 20% of your MIPS score, and I'll get back to that in a moment. And promoting interoperability is required and accounts for 30% of your MIPS score. Now, first, a note on improvement activities. All APM participants by legislation are granted half of the available improvement activity score just for participating in the APM. Medicare annually reviews all APM designs and grants additional improvement score based on the APM requirements. Currently, all APMs earn 100% of available improvement activity score. You don't need to make a submission. Medicare knows if you're in the APM, and they will grant that full score for you. When promoting interoperability, it is required and accounts for 30% of the MIPS score, as I said. You can submit individually, your practice can submit for the group, and new in 2023, your APM can submit for all participants in the APM. That's not a short answer, but hopefully that thoroughly answers your question, Di. Thanks very much for the great question.
Yeah, thank you, Di and Crystal. If you have a question for Dr. Mingle, please leave it in a comment on LinkedIn or YouTube, or send us an email at hello@minglehealth.com. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and my great thanks to Di and Crystal for the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answer. Share your experience, ask your questions. We can be smarter together.